Very good afternoon, everyone. It gives me immense pleasure to speak on this forum where I can see everyone has already spoken at great length about all these alterations. Of course, I'll be covering a part of it. So, interpretation of EGFR exon 20 insertions. So, the brief outline of my talk would be EGFR mutation testing guidelines and why are we looking at exon 20 insertion mutations, the different methods of exon 20 insertion mutation detection, and what is the clinical relevance of these mutations. So the EGFR mutation testing guidelines as per the ESMO, German and Italian Association of Medical Oncology and NCCN guideline recommend routine testing for EGFR exon 20 insertion mutation because detection of these mutations can help guide treatment. And EGFR exon 20 insertion mutations are generally resistant to currently approved EGFR TKIs. So if these mutations are detected, chemotherapies are often prescribed as first-line therapy. So with that, let's look into the evolution of exon 20 insertion mutations, which was first described in the year 2004. And eventually, we have seen the progress of exon 20. We have seen like a response to certain drugs and then overall response rate to the patients, the different types of exon 20 insertions which were uncovered as compared to what we were knowing like a decade ago. And so today it's all about which part of exon 20 insertion, which would then accordingly the treatment would be decided. So if you can look into all those things, EGFR mutations are broadly grouped into three major categories. The classical sensitizing mutations, as we all know, exon 19 deletions and L858R. The atypical uncommon mutations like G71X and L861Q and S768I. And then comes the EGFR exon 20 mutations. So what makes it so special? So if you see, exon 20 comes to the tyrosine kinase domain where exon 19, 20, 21, all these exons are present. Exon 20 is coding for this entire region of the C helix and the loop following the C helix. So if you can see, this exon is encoding for all these amino acids, what you can see here, 761, 2, 3, 4, and so on and so forth. So what we know because of the advancement in the technology is that specific alterations are showing response to specific treatments. So if you can see, if there is amino acid 763, 64 is inserted or it's altered, then they would be showing sensitivity to first generation TKI. Then if it is from 766 to 770, then they have response to poziotinib. Similarly, when it is between 773 to 774, so it's afatinib. So it's not only just knowing whether it is exon 20 positive or negative, it is extremely important to know which region of exon 20 insertion mutation is present. So with that, why is it important? Because these mutations, as I already mentioned, they differ from the common mutations. And if they are undetected, they will leave the patients at a high risk of rapid disease progression. So these are the third most prevalent primary mutations. And compared with the normal mutations, what a difference is EGFR exon 20 insertion mutation is that they reduce the size of the drug binding pocket. This is the loop, and this is because of these alterations, the drug is not able to bind, and so the response is not common. So EGFR exon 20 insertions, the response to TKI has been really poor to the known TKIs. And using normal TKI, the median survival is hardly a few months as compared to the classical treatment given to the known mutations. So as I already said, these are heterogeneous mutations. And with the limited knowledge of the testing which was being done previously, we could only identify very few known alterations. But with the help of NGS, many of those things are being now uncovered. So what are the major pathologic and molecular features of these mutations? These usually occur in lung adenocarcinomas. And these alterations, like what we see for this exon 20 coding for amino acids starting from 761 to 775. So usually they involve either addition of 9 base pairs or 12 base pairs, which would lead to change of some amino acid sequences, which would change the complete frame of these C helix or the far away from the C helix loop or the near loop or far loop mutations. And based on these alterations, they would show their response to the treatment. So how do we detect these EGFR exon 20 insertions? So there are two main ways. One is the polymerase chain reaction, the real-time PCR. Earlier, even conventional Sanger sequencing was also used. Now it is phased out. Then comes the next generation sequencing. Whom and when to test? The clinico-demographic profile of most of these exon 20 insertion patients shows that they are non-smokers with adenocarcinoma histology. And if not tested for exon 20 insertions at the baseline, definitely at relapse, it need to be looked for. So what is the disadvantage of the PCR-based detection is that we need to have a understanding of like what region to look for. So accordingly, the primer pairs would be designed. So with the limited information. So you will be looking at only one specific region at a time. So it would be little time consuming. So for example, this is a classical Sanger sequencing electropherogram, where one can see that there is a peak within the peak. That is, a change of T to G would indicate a change in the amino acid. So that was Sanger, but the major limitation is that the limit of detection or the assay sensitivity, it cannot detect beyond 15% of mutants. So anything lower than that would go undetected. So definitely this is phased out. Then is the real-time PCR, which is still very popularly used. So where you can see these two peaks. So these are based on fluorescent labeled probes for the specific target region one is looking for. So when it comes to exon 20 insertions, though there are so many different insertions are present, the commercially available kits or homegrown assays, we design only a limited set of regions can be designed in a multiplex PCR. So if the presence of a peak indicate that that particular alteration is present, whereas if it is not there and only your PC is there, that means that mutation is absent. So with the advancement in the latest molecular diagnostic technology, the cutting edge techniques, we can see that over the period of time, the detection of these exon 20 mutation insertions has increased. So definitely advanced molecular diagnostics has a role to play. How? Now that is next generation sequencing based detection. So what does it do? It doesn't look for specific regions, or it doesn't have primers probe specific. The only assay is designed in such a way it should have the complete EGFR exon 20 should be there in the panel. So any alteration within any of these regions can be easily detected by the next generation sequencing, making it the most robust, the faster test for detecting these alterations. So according to ESMO guidelines, it's also said that multiplex massively parallel NGS of various sorts is rapidly being adopted as a standard approach to screening the adenocarcinomas for these targets. So far in literature, nearly 102 unique EGFR exon 20 insertion mutation variants have been identified, which definitely varies in various size and their genomic positioning. So how does an NGS report looks like? So usually the report would mention what type of test is being done, what does the result say, whether it is a pathogenic or a likely pathogenic alteration, what mutation. It should also mention about the QC aspects of the assay, like whether how good is the data, if Q30 indicates the sequencing standard, sequencing metrics. And then it should also contain the name of the gene which you're looking for, the alteration that C dot indicates at the transcript level, which regions nucleotides have been changed. So that from 2315 to 2320 means that those many base pairs have been affected. What is the transcript ID for that particular gene one is looking for? And the amino acid change. So if you can see here, from amino acid 772 to 773 has been duplicated here. So, and the frequency of this occurrence of this alteration in this particular sample. So when it is frequency of 38.5%, that means it is definitely a known alteration. So anything more than 5% variant allelic frequency is considered as acceptable. So this is 38.5 in this example. And then what is the type of mutation, whether it is insertion, so it is mentioned, and what kind of a tier it is, that is whether it is a pathogenic or a likely pathogenic and so on. So then it comes to choosing between PCR and NGS. Definitely NGS has an upper hand. PCR-based tests, as I already mentioned, Dr. Tripti also mentioned, have technical limitations and can only detect limited number of mutations. In fact, there have been studies which showed that nearly 50% of the exon 20 insertion mutations have been missed by PCR, which have been picked up by the NGS. So out of the 17 most common exon 20 insertion mutations, if you take any commercial kit, be it Cobas, be it Diatec, be it any other company, they would be having primer probes only for 4 major regions. So that is a major limitation why exon 20 insertions have been missed out and patients have not been responding to the classical therapy. So for every 2 EGFR exon 20 insertion mutations detected by NGS, PCR misses 1. So this is one such study where they compared 2 different NGS methods versus the conventional PCR, and it was shown that nearly 50% of the mutations were missed in this particular case, in this study. So also looking into the TMH data, a retrospective study from TMH has demonstrated that approximately 20% of our patients are with exon 20 insertions, and these patients had a median progression-free survival of nearly 6 months. And So also as Exon 20 awareness has been increased, there is a group has been formed and which spreading awareness, and then it's also providing like for one patient at a time essential patient services, and there have been a lot of research interest has been generated. So definitely Exon 20 spectrum is being expanding, and so is the available biomarkers and the targeted therapies pertaining to that. So with that, I would like to end my talk. Thank you so much.
Thank you, Dr. Omshree. Actually, that is a really wonderful presentation, about Exon 20, and it's really important in the clinical practice because now we have a specific targeted therapies available.